We will be led by Dr. Melissa Tracy from Rush University Medical Center. She will be telling us a little bit more about heart management with kidney disease. And before she begins, I want to just tell you a little bit more about her. Dr. Tracy is an associate professor at Rush University Medical Center. She is the solid organ transplant cardiologist as well as the systems director for cardiac rehabilitation. She specializes in cardiac prevention, women's heart disease, echocardiogram, thank you. I'm sorry about that. My apologies. And solid organ transplantation. She's an avid runner and the proud mother of 3 children. So please join me in welcoming Dr. Melissa Tracy.
Good morning, everybody. I would say of everything that you mentioned, yes, being the proud mother of 3 is the highlight of my life, and tomorrow is Mother's Day, so that's pretty special for me. So with no further ado, I'd like to talk today about heart management with kidney disease. There are several cardiovascular risk factors, and I actually have 2 slides that essentially say the same thing, but I think one may draw your attention a little bit more than the other. But I wanted to go over what are the cardiovascular risk factors, because some of them are modifiable and some of them are non-modifiable. Those that are non-modifiable are your age, your gender for the most part, and your family history. However, if you can see the list of those that are modifiable, which are in your control, are quite a bit longer. Hypertension and the treatment of hypertension, hyperlipidemia, elevated cholesterol, sugar diabetes, especially the control of your sugar diabetes, smoking, and there is not a single number of cigarettes or vapes or Juuls that are safe for our brain, our heart, or our kidneys. Our weight, a healthy BMI, and then sedentary lifestyle. We need to be more active. So again, this is another way of putting exactly what I just put into context, but some people like the fact that I put it in a heart and that gravitates to them more so. But again, these are the modifiable risk factors. You have control. Don't smoke. Get your blood pressure under as optimal a control as possible. And I'm going to go over what is now optimal for patients with CKD. Obesity, a healthy BMI. Cholesterol, having your total cholesterol less than 200. Your LDL, your bad cholesterol, as low as possible. Triglycerides less than 150. And our HDL, our protective cholesterol, as high as possible. Sugar diabetes, having that as well under control as possible. Reducing stress, which I have to admit is probably difficult for all of us, including myself. And then we need to be more active. If you don't want to call it exercise, call it physical activity, call it movement, but please move. So these are some scary statistics that I'd like to share with you. 35% of Americans are obese. 8.3% of Americans have sugar diabetes, and 38% of Americans have pre-diabetes. 30% plus of Americans are inactive. 50% of Americans do not meet the federal aerobic physical activity guidelines recommendations. And 33% of adult Americans have high blood pressure, with a higher propensity of that in our African American population. I wanted to just hit on a few specifics for women. Women are still 1 in 3 women will have the development of cardiovascular disease. Women have similar cardiovascular risk factors than men. However, up to menopause and then possibly about 10 years plus or minus, they still have that protective estrogen. So albeit they still may have those same risk factors, but they do have the protective estrogen. However, there are some specific indications or areas where women are at greater risk, and that is disorders of pregnancy, adverse pregnancy outcomes, and also menopause. I'm not going to hit on these because this is a talk for chronic kidney disease, end-stage renal disease, But please, ladies, we have to make sure that while we're pregnant and while going through menopause, that we're continuing to identify our risk factors and to optimize them. Women and men may have different presentations for heart disease. Women may have more atypical symptoms. They may have more shortness of breath or more fatigue. Men may have more of that pressure chest pain radiating up to their jaw, down their arm. The key is that we as healthcare providers need to listen to you, and we need to see if there's a pattern to your symptoms. Are those symptoms related to stress? Are those symptoms related to activity? Because albeit you may have different symptoms, there typically is a pattern, and that pattern is typically activity and or stress, and then those symptoms are relieved with the relief of the stress or with rest. A lot of patients ask me, do I need a statin? If you have sugar diabetes, you should most likely be on a statin. If you have an LDL cholesterol of greater than 160 to 180, and I'm going to say regardless of age, you should probably be on a statin. And the reason why I say regardless of age is the guidelines don't hit for our younger population. And if you think about LDL cholesterol, it is an oxidative stress on our brain blood vessels, our heart blood vessels, our kidney blood vessels. And that prolonged high elevation of LDL and that oxidative stress on all of those vessels can accelerate disease. If we blunt that oxidative stress with a statin, we blunt the development of cerebrovascular, cardiovascular, and kidney disease. The other question that I get asked a lot, even more than the statin, is, Doc, there's this study out, it's now telling me throw my aspirin away. So here is the summary. We are no longer using aspirin for primary prevention. So in my practice, before this large study was published just a couple years ago, I believe it was published in 2019, it was a large meta-analysis looking at the risk of bleeding and the risk of, or the benefit of lowering cerebrovascular and cardiovascular disease. Prior to that, a man turned 45, a woman turned 55. I was starting them on an aspirin. Now I've taken a step back. I no longer, and none of us should be using aspirin for primary prevention. So it should be used for secondary prevention, or if you have secondary prevention, meaning you've already had a cardiovascular or cerebrovascular event, or if you have evidence of carotid plaque, or you have evidence of calcified cholesterol in your coronaries, or you've had a TIA or stroke. Those are definite. You should be on an aspirin. The maybes include many of you in this room. Chronic kidney disease is a huge risk factor and a huge stress on our system. So that's where there needs to be a shared decision-making between you and your nephrologist or your primary care doctor or your cardiologist as what is the risk versus benefit ratio? Is my risk of bleeding lower, or is my risk of bleeding lower and my benefit higher for being on an aspirin? So please have that discussion with your healthcare providers. There are ways of calculating your risk of heart disease. These are just a couple apps that you can download on your phone. You can actually put in there to ask you your age, your gender. It's going to ask you what your blood pressure is, your cholesterol, and then it's going to ask you if you are on any therapy for these. So please download these apps because, again, an educated patient is empowered. The incidence of chronic kidney disease is rising. And I think any of you that are in this room or any of you that will be listening to this lecture know that, and that's why you're here. The risk or the leveling of end-stage renal disease, that is luckily leveling off. However, Look at these numbers, and these are old numbers. There was a sharp rise in the risk and development of end-stage renal disease. The reason why this has leveled off is because you are taking better care of yourself and we're helping you. So we are getting you to be more optimized with your blood pressure, your sugar, diabetes, your cholesterol. We're getting patients to stop smoking and be more active. But you look at these numbers, still per million, still hundreds of thousands of patients with end-stage renal disease. And I see many different races in this room, but African Americans are struck with end-stage renal disease, CKD, more than any other race. And that is for possibly 3 factors. One, the risk of hypertension greatly is more of a risk factor for African Americans. 2 is the access to health care. 3 is really understanding the risk and making sure that you're working with your healthcare provider. So as you can see, hypertension is a key reason here, but our African American population is clearly more struck by the development of end-stage renal disease. And the financial aspects of end-stage renal disease. So if you look at this, the yearly costs for being on dialysis or peritoneal dialysis are huge. Look at what it is. Let me see if I have yes, I do. This is, the red is with transplant. This is where, first of all, we want to avoid getting you to end-stage renal disease. We want to avoid getting you on any type of peritoneal dialysis or hemodialysis. And if we do get you there, or unfortunately, that's the toll in which your body is taken, we need then to try to see about how quickly can we get you transplanted? Because 1, it's going to be easier on you, and financially, it actually is saving all of us. And as you know, we are spending so much money on healthcare. It is scary if we're going to run out of money to take care of everyone. So here's some transplant facts. There are currently approximately 120,000 people waiting for organ transplants in the US, and most of these are kidney transplants. Only about 20,000 kidney transplants take place in the United States, and that's just because there's not enough donors. On average, 3,000 new patients are added to the kidney wait list each month. 13 people die each day while waiting for a life-saving kidney transplant. Every 14 minutes, someone is added to the kidney transplant list. And annually, nearly 5,000 patients die while waiting for a kidney transplant. Another 4,000 became too sick to receive a kidney transplant. So my role as a solid organ transplant cardiologist is that I need to keep my patients healthy while on the wait list. I need to get them healthy enough to go through transplant. I need to keep them alive in the operating room. I need to keep them alive post-transplant. I need to keep them alive at 30 days, 60 days, 6 months, a year, and beyond. So we really work as a team in our kidney multidisciplinary program. As I stated, I'm the cardiologist, but within that program, we have myself, we have infectious disease, we have our surgeons, we have our nurses, we have our social workers, we have our dietitians. We all work as a team so that we can make patients safe and healthy enough to go through a transplant. So looking at the organ transplant waiting list, look at the percentage, if just as a graphic, how many more patients were waiting for a kidney relative to a liver, heart, pancreas, or lung. It's huge, but we don't have enough donors. So when we are worried about patients with chronic kidney disease, are these really 2 separate organs? There's the heart, or there's the kidney, or are these intertwined? And I will tell you, they are intertwined. Cardiovascular disease is more prominent in all patients with CKD. So that is regardless. So if you're looking at this slide, these are These are the patients with CKD in the blue, and then the yellow are the patients without CKD. And across all of these cardiovascular risk factors, CKD is highest in all of them. So in every patient who has a cardiovascular risk factor, they're more likely to have CKD. And now you break it down into the individual parts, the albumin to creatinine ratio, looking at their GFR. Across the board, CKD is more common in patients with cardiovascular disease, and this is with patients with a high albumin creatinine ratio, as well as those with a low GFR. This is a little bit of a confusing slide, so let me go through it. Kidney dysfunction is associated with increased cardiovascular mortality. So here's GFR. As your kidneys are filtering less, that's what we call the GFR, glomerular filtration rate. As your glomerular filtration rate is declining, so if you go watch my arrow, as it's declining, look what is happening to cardiovascular risk. It's rising. Here's another look. As your albumin to creatinine ratio is rising, so now you're spilling more protein in your urine, your risk of cardiovascular mortality is increasing. This slide is really important. What this slide shows is that independent of high blood pressure, independent of sugar diabetes, so if you have those for diabetes, and if you have hypertension, it's the red. So if you have diabetes, yes, as your glomerular filtration rate reduces, your cardiovascular mortality increases. However, look at this. Even without diabetes, as your glomerular filtration rate decreases, your cardiovascular mortality increases. So having chronic kidney disease with diabetes, the combustible combination, but even without diabetes, the impact on your system of chronic kidney disease is impactful on your heart and poses an increased cardiovascular risk. This is hypertension. So those with hypertension, those without hypertension. Again, look at these graphs, that as your GFR decreases, and even more so in those patients that are even non-hypertensive, your cardiovascular mortality is adversely affected by your chronic kidney disease. And here's kidney dysfunction and other cardiovascular outcomes. So across the board, all-cause mortality, coronary death or non-fatal myocardial infarction, congestive heart failure, or stroke. And these are the patients with the lowest GFR. All of them, every single one of these cardiovascular outcomes has a worse cardiovascular outcome when coupled with chronic kidney disease. And here's a depiction, a cartoon of the kidneys and the heart. They interact, and it's mostly by three factors: inflammation, fibrosis, and then the adverse events with calcification. So as the kidney starts to fail, so here it is with mild to moderate CKD, and then with more significant CKD, the kidneys get smaller because they're functioning poorly, but those factors that impact the heart are even more pronounced. Again, fibrosis, inflammation, and calcification of the vessels. So what happens though once a patient is successfully transplanted? We still have to work on all of those cardiovascular risk factors, because if you look at this pie, and these are all patients, and this is cardiovascular mortality in patients who have now received a kidney transplant. Those that die are most prominently those that are dying from cardiovascular disease. So post-transplant, it's not a party. You can't give up on all of those good things that have gotten you healthy to get to transplant. You've got to maintain still having a healthy life. So, however, and this is really important, that albeit cardiovascular impact is the greatest reason for for mortality post-transplant, if you get a kidney transplant, though, look at how improved your risk of cardiovascular death is. So this is months post-transplant. The yellow is cardiovascular disease after a transplant. The red is cardiovascular disease while on the wait list. Look at this, months out, years out. If we keep you healthy post-transplant, you will have a greater mortality, improved mortality from a cardiovascular perspective. So the first things first, we don't want to get you to end-stage renal disease. Second is that if we get you to end-stage renal disease, and I keep saying if we get you, I don't mean it as, yeah, we get you. Meaning that if, unfortunately, the circumstances are that your CK, you go from normal kidneys to chronic kidney disease to end-stage renal disease because of risk factors or social factors that prohibit you to be able to get the proper health care. The next best thing that what we want to do is get you off of dialysis. So transplant, if you are on dialysis, looking at these outcomes, just look at this 5 years out, that if you are end-stage renal versus you are successfully transplanted, your cardiovascular mortality is so much more improved. And this is cardiovascular death with your serum creatinine post-transplant. So again, we have to keep that transplanted kidney, that gift for another chance, whether it be your first transplant, your second transplant, or your third transplant. We need to keep that kidney as healthy as possible, because as your serum creatinine drops, so does the rate in which, or so does your mortality. So as your serum creatinine on that transplanted kidney, that gift of a transplanted kidney declines, your cardiovascular mortality also declines. So I'm circling back to where I started on the risk factors for cardiovascular disease in transplanted recipients. Still have to take care of your hypertension, still optimize that blood pressure, optimize the lipids, make sure that we are having your sugar diabetes as optimal as possible, trying to avoid CKD from arising in that transplanted kidney. Immunosuppressive drugs are a whole nother lecture in and of itself, but one thing I tell all of my patients who are going for transplant, when you go through transplant, it is giving up one disease, end-stage renal disease, for another. The amount of medications that you're going to be on, the amount of doctor's visits you're going to have to go to, the number of blood vials that we're going to want to take from you, that doesn't change, but your cardiovascular mortality significantly improves. We have to try to avoid rejection. The duration of your time in end-stage renal disease does play a factor, because again, that stress of being in chronic kidney disease or end-stage renal disease has played havoc on your brain, on your heart, and the other vessels in your body. Age, well, that's a beautiful thing, because if we're not aging, we all know what the alternative is to that. That was what we're trying to avoid. No smoking. As I said before, we cannot, there's not a single one cigarette that you can smoke. And now with these vapes that especially our young youth are doing, vaping is not within the realm of what you should be dealing with either, as well as secondhand smoke. You really want to avoid people smoking around you. I want to just hit on this. This was just published, and this is really important for those of you in this room who have high blood pressure. This was just published in the Journal of American College of Cardiology. cardiovascular implications of the new 2021 blood pressure guidelines for adults with CKD. And what I want to point out to this is that patients with CKD, patients with end-stage renal disease, we need that blood pressure regularly, consistently, less than 120/80. The old guidelines, the 2012, patients who were spilling urine, albumin protein in their urine, we said less than or equal to 130/80, and without spilling protein in your urine, less than or equal to 140/90. The ACC, American College of Cardiology, and the American Heart Association in 2017 said 130/80. The new guidelines, systolic blood pressure less than 120. Now, if you're symptomatic, dizzy, lightheaded, fatigue, okay, we have to work with what we can because we also want your quality of life to be optimal. But look at this. If you look at this, in this small quadrant, these are the patients who have control of their blood pressure. Sorry, this touchscreen is a little bit sensitive. So these patients have control of their blood pressure. This is the diastolic. This is your bottom number. This is the top number, systolic. Look at all of these patients. If you're looking at all three of those guidelines, the 2012, the 2017, and then looking at the 2021, most patients with CKD do not have their blood pressure under control. And then looking at the cumulative risk of cardiovascular disease. This purple are those patients out here. All of these purple dots where they're above all of the guidelines, their incidence of cardiovascular disease surpasses everyone. So we have to get the blood pressure under control early. If we get the blood pressure control under early, that will help with avoiding the CKD from accelerating. If though it accelerates and you get to end stage renal disease, we have to continue to keep that blood pressure under control. Otherwise, your cardiovascular risk is increased. And so what are the things that we're worried about? Well, one of them is heart failure. And the reason why a lot of patients with end-stage renal disease develop heart failure is for two factors: volume overload and the development of coronary artery disease. The volume overload, and I should actually say three, and fibrosis. So the volume overload from because your kidneys are not filtering and functioning properly, you get dialysis, the volume is dropped, you go to dialysis in 2 days, and in that day, the volume is up. And so your body is constantly oscillating between a high volume, a low volume, a high volume, a low volume. The heart starts to think, I'm schizophrenic and I don't know what to do. It will tolerate that for a while, but then it can start to dilate and fail. In addition, with CKD, you can have, because of the uremic, because of the inability for the kidneys to clear, you have a constant buildup of toxins. That can now develop fibrosis into the myocardium and develop heart failure. And then third reason is coronary artery disease, the development of plaque, and then possibly the development of heart attacks. So we can develop heart failure, which we want to avoid. How do we evaluate you from a cardiovascular perspective? So think of the heart like a house. The house has structure, the heart has plumbing, and the heart has electrical. So an EKG, probably all of us in this room have had an EKG. That is one method to tell us about the electrical activity in the heart. Is the heart rate going too fast? Is the heart rate going too slow? Are there any blockages in or pauses or bradycardia? What is the conduction? What is the electrical activity of our house, of our heart? The next thing is the structure. The heart has two atrium, a right atrium and a left atrium. Those are connected to a right ventricle and a left ventricle. And if I go back here, this is the right atrium, this is the right ventricle. Here's the left atrium. Here's the left ventricle. And then we have valves. We have doors. And we have a tricuspid valve. We have a pulmonic valve. We have a mitral valve. And we have an aortic valve. So the echocardiogram, which many of you may have had, the ultrasound of your heart, that tells us about the structure of the heart. What are the sizes of these chambers? What is the thickness of these chambers? What is the pumping function of these chambers? That's called the systolic function. But what is also the relaxation of the heart? We want to also look at how well is the heart relaxing, because as our cardiovascular risk factors develop, as blood pressure is allowed to be out of control, as CKD goes to end-stage renal disease, not only can that affect the systolic, the pumping function of our heart, it can affect the relaxation of our heart. And now our hearts become more stiff and it can't accept the volume as easily as it could before. And then all of that increased pressure goes back to the lungs, goes back to the right heart. Now we can have left heart dysfunction and we can have right heart dysfunction. So the echocardiogram tells us structure. Many of you may have had a stress test. One of the ways that we screen patients, we want to screen them. We may have you walk on a treadmill, or we may give you the medicine in your IV to let us know how well the plumbing now, what is happening with the plumbing of the heart. So the stress test, one of the reasons why I like an exercise stress test rather than the pharmacological stress test, is that we can look at the heart rate at rest, blood pressure at rest, then what's happening to the heart rate and blood pressure with exercise and recovery. We can look to see if there's any development of any arrhythmias, irregular heart rhythms, and by whichever stress test you do, whether that's a nuclear stress test or an echo stress test, we now can ascertain how good is that plumbing. It's not telling us if you have no coronary disease, but it's letting us know that what is in your coronaries, if at all, is or is not hemodynamically significant. And what I mean by that is you're not going to call a plumber right away if you're not going to call a plumber at all if your toilet is flushing. If you notice that the toilet is not flushing fully, you're going to keep an eye on that. And then if you get a backage, you know you need to call the plumber. Well, the stress test helps us. If we see that all of the areas of the heart are getting enough blood supply, we don't need to send you for an angiogram. If we notice that maybe there's a little bit of blockage, meaning there's a little bit of area of the heart not getting enough blood supply, or the thickening or contractility of the heart is just mildly dysfunctional, we're going to look at all of your cardiovascular risk factors and say, where can we optimize those cardiovascular risk factors? And then if we see something on the stress test that's significant, that indicates a more significant blockage, then we're going to possibly send you for a coronary angiography or an angiogram. And this angiogram can be done via the arm or the groin or in the bend of the leg. Right in the bend of the leg, we have the femoral artery. So it can be done via the femoral artery, or we can do this by the arm. And we send catheters up the aorta and we engage into the coronary arteries. And we can see if there's any blockages. So this is an angiography of a patient with normal. This is the normal coronary. This is the left main coronary artery. This is the left anterior descending coronary artery and the left circumflex. And then there's a right coronary. And so these are pictures of a patient with normal coronaries. So we have several tools to look at before we have to get to something invasive. EKG, echocardiogram or ultrasound of the heart, stress test, and optimizing all of our cardiovascular risk factors. And I'd like to thank everybody for their attention today. And please, let's hope that things get better for our friends in Ukraine. Thank you, everybody.
All right, thank you again, Dr. Tracy. And we do have time for maybe one or two questions if anyone would like to ask. All right, Terry, I'll come right over. Thank you.
First and foremost, Dr. Tracy, thank you for your presentation today. very enjoyable. One thing you didn't touch on, and I had this happen to me during my dialysis journey, my IPTH went off the rails, and initially they tried to prescribe me medication, but I was working with another hospital, Mayo Clinic, where they said, you need to come on in and we're gonna remove your parathyroids because you have hyperparathyroid activity, which is just driving you off the map.
Yes.
And then you mentioned something at the end of your presentation relative to the angiogram. Now, I'm had a transplant and going to be transplanted again sometime in the future. But while my little bit of kidney function is working, I've been informed that they won't do the angiogram until I have to go on dialysis, because shooting the dye into me now would kill whatever little bit of kidney function I have. But the chronic kidney disease coupled with heart failure is essentially important, because it knocks so many people out of contention of being a viable candidate for transplantation, because you're utilizing at least 20 to 25 pounds of saline fluid being pumped into the heart and have to be regenerated for the transplant recipient to be able to continue to function. But thank you so much for your presentation. I'm a yield the floor now.
Yes, I did not hit on hyperparathyroidism, but I have had patients, because of their hyperparathyroidism, have greater calcification, not only in their coronaries, but also of their heart valves. So then they can develop problems with their mitral valve and aortic valve specifically. I've also had patients whose lipids are off the radar, and once they get their parathyroids removed, we can now get their cholesterol under control. So that hyperparathyroidism absolutely can affect the coronaries, can affect the valves, can affect the cerebral vessels. So yes, if they cannot get your parathyroid and your calcium levels under control with medicines, the parathyroids have to come out for sure. And yes, we have to definitely, what we do at Rush is that if a patient has some kidney function and we know that there's a risk, we can't predict it, but we know there is a risk. If their symptoms or their ultrasound of their heart or their stress tests are mild, minimal to no symptoms, preserved left ventricular ejection fraction, and mildly abnormal stress tests or no high risk factors on the stress test, we will wait until a patient is either on the day of their transplant, we'll cath them, or once they go on dialysis. If though the findings that their ejection fraction is dropping on their echo, or we notice that they have some high risk factors on their stress test, we have to cath them, because now their heart may not survive if we don't do something. And if the heart isn't surviving, now they're looking at a heart kidney transplant, or now we're looking at death. Or that the patient has a major event to their heart and now they are no longer a candidate. So you're absolutely right. We do not, if there's a chance that we can keep that patient out of the cath lab and optimize their risk factors, we will do that. But if there are any high risk findings on the stress test, or we see that their pumping function is declining and we don't know if that's coronary disease, we'll talk to the patient. We'll say, listen, we think your heart is at risk and we got to check out the heart. And it's a shared decision making with the patient. I wish you good luck.
All right, Dr. Tracy, we have one final question here as well.
I have had problems with my blood pressure. As a matter of fact, that's what started me on dialysis, was the blood pressure. Now, it was extremely high when I started. That was 17 years ago. Now it's low. I was taking high blood pressure pills. Now I'm taking low blood pressure pills. So You were saying about the, that you would recommend it be under 120 over 80, right? So now my numbers are going to like 107 over 60, and it drops during dialysis. It could go as far as 80, or even 70. And then I'm feeling like my head feels light and I'm extremely lethargic. And so they cut off the machine. But I'm wondering, so how do we get that balance of where we actually should be as far as our optimal blood pressure when we're dealing with dialysis?
So your 106 over 70 is beautiful. The difficult part is for you, because your blood pressure drops, would be for them to have you on dialysis, on the treatment for longer. So instead of trying to get in 2 or 3 hours the volume off, would be to have you over a span of maybe 4 hours, or have you, instead of 3 days a week at 3 hours, have you at 4 days a week for 2 hours. So there are ways to work that. I'm assuming you're on methodopa, or are you on anything? Not methodopa, midodrine. Sorry. Are you on midodrine or on Florinef? Midodrine. So how are you taking your midodrine?
Right now, I'm on my days off, 15 milligrams. On my days on, 20 to 30.
Okay, but when are your days on, when are you taking that? On means on dialysis days, right? When are you taking your midodrine?
I take it right before, because I was taking it like an hour before when I'm at home. Now when I get to dialysis, about 4:45, because I go on around 5. So I take it about 4:45, of which I get to dialysis. Then I take it about 4:42, and then usually I could go on with 20 milligrams. But if I take it before, like 3:45, then I usually have to take another one, and I go to 30 milligrams.
So you could try taking during, not before dialysis, but during dialysis, and then immediately following dialysis. You could try that as well. That may help. So yes, we absolutely, once we take away the need of the kidneys to utilize what they're supposed to be doing because they have failed, and we put you on dialysis, now we have this robust cleaning machine. But the body is not necessarily wanting it to be so robust. The body is saying, listen, I want to be more consistent. And again, we have this oscillating factor. So on dialysis days, you may want to take it during dialysis, and or with an hour in, and then right after. You could try that. You're welcome.
All right, well, I think we'll stop there in the interest of time. Thank you again, Dr. Tracy. Please, everyone, join me in thanking Dr. Tracy for her presentation.
Thank you, everyone.